Welcome to the Blue Sky Institute's Total Joint Arthroplasties training. Introduction. Total joint arthroplasties are very common procedures that can be elective or due to trauma. This discussion will encompass hip, knee, shoulder, and reverse shoulder procedures. In 2016, Medicare initiated a Comprehensive Care for Joint Replacement model, or CJR model, for lower extremity hip and knee joints. The model is an attempt to reduce the medical costs associated with treating patients after a lower extremity hip or knee joint arthroplasty. In response to the CJR plan, Blue Sky Therapy has developed several lower extremity joint pathways to assist therapists with providing optimal and efficient care to patients status post-arthroplasty at various functional levels. The pathways can be found on the shared drive. Aftercare for joint replacements should be coded as a Z code and should not be used if treatment is directed at a current acute disease. The ICD-10 Z47.1 aftercare following joint replacement can be used. However, with these codes, you must also use an additional number to identify the joint replaced. Remember not to code conditions that no longer exist after the arthroplasty, such as osteoarthritis or fracture. Those conditions cannot exist on an arthroplasty. Some possible secondary medical or treatment diagnoses can be muscle weakness, disturbance of skin sensation, muscle spasm or wasting, or pain in the limb. Some other possible secondary medical or treatment diagnoses can be swelling of the limb, other lack of coordination, difficulty walking, abnormal posture, or other abnormalities of gait and mobility. Ataxic gait, paralytic gait, or unsteadiness of feet could also be used. This list is not all-inclusive, but are some of the more commonly used codes. Pain is common after any surgery. Dr. Abraham Rasool Jr. recommends administering pain medicine around the clock instead of on a PRN basis. With PRN medications, patients tend to take them right before therapy when they have not yet taken full effect, and patients complain of pain and are not as cooperative as they would be during therapy if they were on a regular schedule. Balance. Balance progression should go from a wide to a narrow base of support, a firm to an unstable surface, eyes open to eyes closed, single limb stance as weight-bearing status allows, flat to uneven surfaces, slow to fast walking, and forward to multi-directional movements. Always obtain a weight-bearing status on evaluation of a joint arthroplasty patient in the chart. If none is given in the chart, the PT should call the surgeon's office or the hospital to obtain one. Walker height. Although 20 degrees of elbow flexion is typically recommended with the elderly population, 30 degrees is optimal for proper standing posture or stability if they have a forward flexed or kyphotic posture. Let's begin with total hip arthroplasties. Types of procedures. A total hip arthroplasty is replacement of the femoral head and the acetabular articular surface. A hemiarthroplasty is replacement of the femoral head only. A bipolar hemiarthroplasty is a specific form of hemiarthroplasty in which a femoral prosthesis is used with an articulating acetabular component. The acetabular cartilage is not replaced. The principle of this procedure is to decrease the frictional wear between the femoral head prosthesis and the cartilage of the acetabulum. Cemented joint arthroplasty occur when bone cement or polymethyl methacrylate is used to fix the prosthesis in place in the joint. In this case, the patient will usually be weight-bearing as tolerated. An ingrowth or cementless joint arthroplasty does not involve bone cement to fix the prosthesis in place. Instead, an anatomic or press fit with bone ingrowth into the surface of the prosthesis leads to a stable fixation. In this case, the patient will usually be partial or toe-touch weight-bearing. A primary joint arthroplasty is a patient's first replacement surgery. A revision is a patient's second or succeeding surgery. It is usually performed for an unstable, loose, or painful joint or an infected joint. Evaluation. A therapy evaluation on arthroplasty surgery should include a review of the surgical report, looking at the incision, hip passive and active range of motion within precautions, total lower extremity strength within precautions, edema, a functional assessment, assessment for PT and ADL assessment for OT, pain, and precaution education. Suggested outcome measures for PT are the 6-minute walk test, the time to the middle, dynamic gait index, the Burr back scale, the lower extremity functional scale, the back or hair hip scale. Suggested outcome measures for OT are the Barthel index under item, the routine task inventory, or the physical self-maintenance scale. All of these tests can be found in your function assessment tools folder. Post-surgical complications include infection, although the occurrence is 1% or less after arthroplasty, DVT or pulmonary embolism, which also are pretty low occurrence. Okay. In complications to be concerned with after hip arthroplasty, dislocation. Posterior dislocation is most common due to flexion disease, SID chair's low, or adductor crowding, or internal rotation, or combination of external and internal rotation, or bending forward with legs crossed. Another post-surgical complication in the hand is leg length discrepancy. This would be corrected by surgery or begun. If it is corrected with a lift, it is recommended to wait at least 6 to 8 weeks after surgery to wait to go down to go and get a improvement of the discrepancy. Warning signs of possible infection include increased redness, tenderness, swelling of wound, drain from wound, chill or shaking, increased pain, both activity and at rest, and fever greater than 100 degrees or more. Warning signs of a possible DVT are increased pain in the calf area, tenderness or redness above or below the knee, increased swelling in the calf, ankle, and foot, and warmth. Warmth can also be caused by normal inflammation. Clinical observation of signs and symptoms of a DVT is not reliable. The accuracy of relying on signs and symptoms alone in identifying a DVT is less than 50%. Therefore, it is recommended that testing is done with a Doppler at any suggestion of a DVT. However, keep in mind that the prevalence of a DVT after a total hip arthroplasty is clinically insignificant. There are a few different surgical approaches to total hip arthroplasties. In the anterior lateral approach, no muscle is cut. The dissection occurs between the sartorius and tensor fascia lata, which avoids abductor weakness. The anterior approach is less common than the posterior approach, although it has recently become more common. The precautions for the anterior approach are no extension and external rotation or a combination of the two, no bridging, and no straight leg raising. The iliopsoas pulls on the femur and can pull it out or dislocate during a straight leg raise. There is also an anterior mini approach in which there's a very small incision, no muscle is cut, and there are minimal hip precautions. There is quicker stability with this approach. However, it is very surgically challenging. It requires an expensive table, and it's technically difficult. Few surgeons are trained on it, and there is longer surgery requirements, which means decreased profit and increased risk. The most common surgical approach is the posterior lateral approach. In this approach, they cut through the muscle, but with minimal trauma to the hip abductors. There are increased dislocation rates with this approach. It is the most common approach, and the precautions are no flexion beyond 90 degrees, no internal rotation of the hip, and no adduction across the midline of the body. An abduction pillow is typically recommended. In long-term care settings, physical therapy treatments should be BID with hip and knee arthroplasties. The treatments should focus on pain reduction and edema control, posture, range of motion, hip precaution education, X within the hip precautions, and functional mobility training, bed mobility and transfer training while maintaining hip precautions. Balance, gait and stair climbing at the level that is needed for a safe return home, and safety while maintaining weight-bearing status, as well as car transfers. General strength training of the lower extremities can be done, including quadriceps, hamstrings, straight leg raises, and heel slides, and the focus should be on gluteus medius strengthening to reduce the Trendelenburg gait pattern that is common after hip replacement. For functional mobility training, patients need to learn how to do all of their daily activities while maintaining hip precautions. Getting out of bed seems to be difficult for many hip patients. First, they need to scoot to the edge of the bed in supine, and then they need to move their foot first to then bridge and move their hip over. If they move their hips first and their foot stays in place, it will cause them to adduct the hip. Avoid side lying and log rolling to get out of bed, and instead have them drop their legs off the bed while coming up onto their elbows, maintaining good alignment, avoiding hip adduction or internal rotation, and then turn and come up onto the hands. They should lean back while scooting forward to the edge of the bed to avoid flexing the hips beyond 90 degrees.
When getting somebody up from supine to sit with hip precautions, you have to keep in mind their precautions. Specifically, they're not allowed to bend past 90 degrees. They're not allowed to adduct the leg across the midline of the body, and they're not allowed to internally rotate that leg. So we need to keep this hip and knee and shoulder all in alignment as she goes to sit up. So first thing we want to think about is scooting to the edge of the bed. So if she is lying in the middle of the bed, let's say it's her left hip that had the operation. If she goes to scoot to the edge of the bed with her hips first, go ahead and move your hips over, and not her feet, you can see she's adducted across the midline of her body, and this is not good. So go ahead back to the middle. You want to make sure if it's her left hip and she's moving to the left side of the bed that she moves her foot first, okay, and then her hips over, okay? If she's had her left leg operated on and she's going to the right side of the bed, you want to make sure that she doesn't take her foot first or her feet first. If she does, bring your feet over. You can see her leg is adducted. So come back to the middle. You always want to take your hips first in that case. So hips over, then she's abducted, and that's okay. And then she can bring her leg to midline only from there. Okay? So we'll have you come back over to this side. Feet first, all the way over, and then hips and trunk. Okay, from here, to get her up to sitting, we don't want to have her do a log roll and roll to her side because that will probably cause her to adduct and internally rotate that leg. So instead, we want to make sure the hips, knees, and shoulders stay in alignment, and you can help here if needed, and you can help here and just have her sit up, keeping everything in alignment together. Okay? Now from here, she's going to want to scoot forward a little bit before standing up. So it's tempting to want to grab the edge and scoot forward this way, but as you can see right here, her hips are past 90 degrees flexion. So this is not maintaining precautions. So instead, we want to teach them to put their hands behind them and scoot forward this way. That way she's not flexing too much. For sit to stand with hip precautions, you want to have your patient go ahead and stand using the walker. Usually they'll be weight bearing as tolerated, but they may be partial weight bearing. So make sure they're following their their weight bearing precautions. Now, to get over to the strong side, if she doesn't want to put any weight on this left leg, she may try to keep her foot planted and just twist into the chair. That's very easy to injure your knee by doing that. So you want to make sure if she's not doing that, try to have her move her heel and pivot like that, little steps, or even take a little step. There you go. And as she gets over there, you want to keep going till she backs up her uninvolved leg all the way up to the chair, and then take the involved leg out in front. Reach back with their hands. Now from here, it's very tempting for patients to want to really lean forward as they sit. This is causing too much flexion at the hip. So make sure that she keeps her chest and head up as she goes to sit down. Good. Okay. And likewise, when she goes to stand back up, it's very tempting if their legs and their quads are weak to try to get hip extension momentum so by bending really far forward and then standing up using their back extensors and their hip extensors. So you want to avoid that by having them keep their head and chest up and stand up. If they're unable to do that, then you need to help them a little bit, but don't let them bend their hips too much. And that's how you do sit to stand and stand pivot transfers with hip precautions.
The following are common issues in gait after total hip replacement, defined by David F. Scott, MD, from the Spokane Joint Replacement Center. One common issue is taking a long step or stride on the involved leg and a short stride on the uninvolved leg. This is done not only to prevent weight bearing on the involved side, but to prevent hip extension of the involved hip, which can cause pain in the groin area. The treatment is to stretch the hip into hip extension, which will help decrease this pain and enable normal equal stride length. During gait, have the patient try to take longer strides on the uninvolved leg. Another issue is early knee flexion at terminal stance or pre-swing on the involved side. This is also done to avoid extending the hip at terminal stance on the involved side. The treatment is to instruct the patient to try to keep the heel of the involved leg on the ground the same amount of time as the uninvolved leg. And another common issue is leaning forward at the waist prior to push-off with the extended operative leg. Again, also trying to avoid hip extension. The treatment in this case is to instruct the patient to concentrate on keeping their shoulders back and walking upright, taking even strides on both legs. And lastly, the Trendelenburg gait pattern. The gluteus medius of the operative leg often weakens after surgery. Normally, this muscle functions in stance to keep the pelvis level during swing on the opposite side. If weak, the patient's opposite or uninvolved hip may drop, or they will lean onto their trunk over the involved leg to keep it level, or both. It is not recommended to discontinue a walking aid until the gait pattern has normalized. If the patient feels they do not need a walker anymore, it is recommended to progress to a cane in the hand opposite the hip replacement. To discontinue the cane, the patient should be able to walk without a limp and have a negative Trendelenburg without a device. In addition, some physicians require an X-ray or physician clearance prior to discontinuing the device. A Trendelenburg sign can be tested to see if a patient is ready to get rid of their assistive device. To do the test, have the patient perform a single leg stance on the operative leg. If the pelvis remains level, then they are ready to progress to ambulation without a device.
One of the most common abnormalities that you will see after hip replacement is what's called a Trendelenburg gait pattern. This is when a patient is walking when they bear weight on the operative side. In this case, we're going to say her left side was operated on. So when she bears weight on the left side and her right side is in the air during swing, the right side of the hip will drop. So the gluteus medius is the muscle that they cut through during the operation, and it gets very weak after surgery. The purpose of the gluteus medius muscle is to stabilize the pelvis and keep it level during gait. So when this muscle is weak, when she bears weight on the left and lifts her right leg, the right pelvis will drop. So when you see a right pelvis drop during left weight bearing, that is considered a left Trendelenburg gait pattern, or a positive left Trendelenburg. So you want to, when a patient is ready to get rid of their walker, or they think they're ready to get rid of the walker and progress to no device or a cane, what you want to do is test this pattern, because you really want them to be able to keep their pelvis level as they walk before they do that. So you can do a Trendelenburg gait test, or a pattern test. So what you can do here is put both of your thumbs over the posterior superior iliac spines, right there, And now most patients will have a level PSISs on both sides, but keep in mind some may not. Especially after a hip replacement, if they didn't quite get the length right, they may have a shortened leg on that side. So in that case, you would see your left thumb would be lower than your right because they have a shorter leg now. Some patients also just have a congenital leg length difference that they've always had. They may be slightly higher or lower. And some may have a pelvic rotation. So keep in mind where you start. Hopefully you start with them level, but if in the case where the hip was shortened on the operative side and you start with that side lower, then that's going to be your baseline. So keep that in mind. So from here, what I'm going to have her do, remember this is her left leg that we had operated on, so I'm going to have her, obviously you wouldn't do this until their weight bearing is tolerated and able to tolerate weight on single leg stance. Because that's what they need to be able to do before progressing to no assistive device. So I'm going to have her, with my thumbs in place, have her lift her right leg up. Okay. Now, as she does that, go ahead and lift it up and hold it up. My thumbs stay in place. So this is called a negative Trendelenburg assessment or test. So that means that she's able to keep her pelvis stable when she bears weight on that operative leg. So in that case, she's good to go to progress to no assisted device. Maybe start with a cane if she's a little uncomfortable. Now, in the case where if her leg was short on the left and she started out here with the left thumb being lower and then she lifted up her leg, you'd want to watch. If the thumbs are now even when she lifts her leg up, that means that that right side dropped. So keep that in mind. In order for that to be a negative test, if she's starting lower on the left, she would have to remain lower on the left as she lifts her leg. So if she's even, again, the way that you can, there's 3 different ways that you can get a positive Trendelenburg test. The first is if she lifts her right leg up and the right thumb or the right PSIS drops. Go ahead and lift up. If the right PSIS drops, then you know that this gluteus medius on the left is not stabilizing the right side of the pelvis and it's dropping. So that's considered a left Trendelenburg. The other case is where maybe they stay stable as she lifts her leg up, but her trunk leans way over the right to do that. What she's doing here is her body, without really realizing it, doesn't want this hip to drop, so she's using that quadratus lumborum by leaning over and pulling her pelvis up using the wrong muscles. So we don't want her to do that. That's a negative or a positive Trendelenburg. Even though she's staying stable, she's doing it with the wrong muscles. So we want her to stay on the walker a little longer while we strengthen the gluteus medius. In that case, that's where we would do a quadratus lumborum stretch on the opposite side, as well as gluteus medius strengthening on the operative side. The third thing is if you try to have her lift up on a leg and she immediately loses her balance and you have to hold her up, then obviously she's not ready to get rid of the walker yet. So those are the 3 things you want to look for. Is she able to keep her hips level as she bears weight on the operative side? Or does one side drop, the opposite side drop? Or does her trunk lean over? Or does she lose her balance?
Stair training should begin with a step 2 pattern leading with the uninvolved leg when going up and the involved leg when going down. Progress to a step through pattern when able, but make sure they maintain less than 90 degrees of hip flexion and all precautions while ascending and descending the stairs. All the major muscle groups of the lower extremity and core should be strengthened with emphasis on hip abduction and extension. Strengthening of the gluteus medius on the involved leg side can be done with sitting or standing in an open chain, hip abduction, but it is better done in a closed chain, as this is how the muscle needs to work during gait to prevent the Trendelenburg pattern, or in side lying, as it forces it to work against gravity. You can begin with sitting hip hikes if this is too difficult for the patient to do in standing, but when able, progress to hip hikes in the parallel bars and standing on a step if able. Stretching. The hip flexors need to be stretched into extension to make sure that to bend the knee to get the rectus femoris as well. Quadratus lumborum needs to be stretched in heel cords.
So in order to strengthen the gluteus medius when you have a Trendelenburg gait pattern, it's important that you strengthen it in the way that it's used functionally during gait, which is in a closed chain. You can also strengthen it in an open chain by just doing open chain hip abduction exercises, and those are good exercises to do. But the way that that muscle works during gait is in a closed chain. So when you bear weight on the left side, it needs to work that way to prevent the right side from dropping. So to strengthen that muscle in a closed chain, you would need to do a hip hike. So standing on your left leg, hiking your right hip up, just like this. Now this is often very difficult for an older patient to conceptualize this motion. They tend to want to either squat like this, so you have to tell them to make sure to keep that left leg straight, or they want to bend and do more of a knee flexion exercise. So you have to tell them to keep the other knee bent, but don't move it after that. And it's just a motion like this, up and down. So if they are unable to do that, or maybe they're not weight bearing as tolerated yet and not allowed to do that yet, you can always start in sitting, and that's a good place to start. So what you can have her do, if her left gluteus medius needs strengthened, she can just hike her right hip up and down, just like that. Good. And so once she's able to do that, and you really don't need to do this bilaterally, because it's usually just the left side that's weak, but you could do it bilaterally. Okay. From there, you can progress to doing it standing with a walker. Okay. Okay, and then just kind of hike the hip up. Very good. Now, if she's having a hard time with this, sometimes patients just don't have enough strength to really get the foot off the floor when they do that. So you can have them, and I would only do this in the parallel bars. We're going to have the walker for the purpose of the video, but in reality, you would start in the parallel bars. You'd have her step onto the step. You want to make sure that they're in the parallel bars when they do this, and that the parallel bars are up high, maybe even slightly higher than this. This is as high as this walker will go for the sake of our video, but you don't want them doing this exercise in a flexed position. Okay, you want them up tall, and then you're going to have her just take her leg off the side of the step here and just take the hips up and down. Sometimes being able to go lower than the other foot helps them. Again, what they're going to want to do is bend the left knee, do more of a squat. You don't want to let them do that. Or they may try to bend this knee and do more of a knee flexion exercise. You want to avoid that. Tell them to keep both knees straight. Don't let them bend at all, and just move the hips up and down. After hip replacement, one of the most common issues that you see is a hip flexion contracture. This can happen from muscle shortness of the iliopsoas muscle, because oftentimes in bed they want to keep a pillow under their knees or their legs elevated and their hip becomes tight. So you want to make sure you avoid that. But also it can occur from capsular tightness in the joint itself. So we want to make sure that we're always doing hip extension stretching. This is the most common reason why you will have gait problems with walking, is because limited hip extension will change the gait pattern. So before correcting their walking pattern, we need to stretch their hip if it's contracted. So what you want to do in this case, remember, she cannot adduct across the midline of her body, so that's why we have a pillow here, not allowing her to do that. So if I'm going to have her stretch into hip extension, you may want to actually move the whole pillow with you and pull her back, or you can use your hands, but just make sure as you pull back that you're not allowing her to drop and adduct that hip. So keep her up in neutral and pull back into hip extension. And you want to make sure as you do this, most patients are going to want to roll back with you, and then you're not extending their hip. So you want to keep your hand here to prevent them and block them from doing that. Get back into the hip extension. Now, a lot of patients won't be able to go near this far after hip replacement. You get them as far as they can go comfortably till they feel a good stretch. And then you want to make sure that you're getting, remember, your quadriceps muscles, most of the three stop here, but the rectus femoris goes across the knee. So you want to make sure to get that muscle as well. You can only do that by bending the knee, so you want to bend that back as you hold that stretch and get that muscle as well. Okay. Another thing that you can do, let me put this pillow in here, is a quadratus lumborum stretch. Now, this is a good thing to do on the side, on both sides, and you want to make sure that this quadratus lumborum muscle is not tightening, which will pull the hip up into retraction. So we want to stretch that by first taking her arm, going up above. Now, if this is an older patient and they don't have the range of motion to do that, you can maybe have them supported on a pillow like this, but just up as much as you can. And then you're just getting your handhold on the rib cage and on the pelvis here, and just doing a little myofascial release, just pulling. Now you want to make sure that you're not stretching just the shirt, give some laxity in the shirt, and just giving some myofascial release and pulling and holding that. And you might want to change your grip a couple times. Just like that, and holding for maybe a good 20 seconds, a couple times to give that muscle a good stretch.
Car transfers. First, move the seat back as far as it will go. Recline the seat back about halfway down. If the car is low, place a pillow on the seat to avoid excessive hip flexion. Have the patient face away from the seat and back up. If the car is low, make sure to have the patient step forward with the involved leg prior to sitting to avoid pain when they sit. Have them sit first and then turn and get the legs into the car, making sure to keep within precautions. When they lift the involved leg into the seat, they will need to lean their trunk back to avoid excessive hip flexion. Once in the seat, they can pull the seat back up to sit upright as long as they don't flex beyond 90 degrees. Getting out of a low car seat is difficult without leaning forward. Make sure they get their legs out first and then scoot all the way to the edge of the seat before standing. Don't hold on to car doors as they move and can cause loss of balance during the transfer. After total hip arthroplasty, hip flexion contractures often occur as a result of a tightened joint capsule, as opposed to osteoarthritis or a short iliopsoas muscle. These contractures can cause the low back to extend excessively to stand upright, which leads to pain. Hip extension and abduction strengthening are often missed or underutilized in therapy after total hip arthroplasty. Treatment for occupational therapy after total hip arthroplasty should include hip precautions education, balance, transfers, toilet, tub, and shower, hygiene, ADLs and dressing, adaptive equipment if needed, DME needs assessment for the home and household activities, and all of the above need to be instructed with maintenance of hip precautions. Focus on balance during functional activities and with upper extremity reaching outside of the base of support. Adaptive equipment. The resident will need a reacher to dress and reach and pick up objects off the floor. They will need a sock aid, a long-handled sponge, a leg lifter for the bed and car may be needed, and possibly long-handled cleaning aids if they're going home alone and will be cleaning. Each facility should have some of these items on hand to practice with, and they can have necessary items ordered for them after returning home. Keep in mind that these items are not typically covered by insurance, so please let the patient be aware that they may receive a bill for them. With dressing, always dress the surgical side first when donning your pants. When sitting on the edge of the bed, make sure that the patient is not flexed beyond 90 degrees and does not lean forward. Prepare for any home needs that they may need. If they have a pet and live alone, they may need to use a reacher to feed them. However, that's difficult to do with a dog bowl, especially with water. So you may want to consider a long-handled feeding bowl like the one pictured here, which can be ordered on Amazon.com. Consider carrying a cup of coffee or water from the counter to the table. If unable to do this and they live alone, they may need a walker tray with a cup holder. For dressing and ADLs, use a sock aid and a reacher or shoehorn to avoid bending while donning and doffing the shoes. If sitting on the edge of the bed, have the patient scoot to the edge, leaning back while scooting instead of forward. A home safety assessment is recommended if able. For stairs, it is imperative to know the number of stairs required to get into the home, and if, where, and how many rails there are. Once in, do they need to go upstairs to the bedroom or downstairs to the shower? If so, how many stairs and rails are there? What side is the rail on? If there are 2 rails, can they reach them both at the same time? How steep are the stairs, and how sturdy are the rails? If they use an assisted device and are planning on spending a lot of time on various floors in the house, they will need a device for each floor if they are going to be alone, or they will need to be able to walk up and down the stairs with the device. Canes are good to have and to be left at the stairwell to assist with going up and down if needed. Look at the bathroom setup. If you are recommending a shower or a tub bench or a chair, make sure the setup will allow for it. Is the toilet in the way? A bench cannot be used with shower doors. Can they be removed temporarily? Are hand or grab bars needed? If they use a shower chair, it needs to be backless to allow them to lean back when lifting the leg to clean the foot or to bring the foot over the edge of the tub. They will also need an elevated toilet seat. Ask the patient where they typically sit during the day. Most people have a favorite chair. Then take a look at the path from there to the kitchen, bathroom, and bedroom. Check for clutter or obstructions that will make it impossible for a walker to get through. Take a look at the cupboards in the kitchen and the bathroom. Make sure that any commonly used items are temporarily placed at a level where the patient will not have to bend down or reach out of their base of support to reach them. In the bedroom, make sure there is an easily accessible pathway to the bathroom with the raised seat. Or you can recommend a 3-in-1 commode to be placed over the toilet during the day and in the room at night. However, do not recommend this if the patient lives alone, as they will not be able to move it back and forth themselves. Instruct the patient to tuck in any bedspreads to avoid tripping on them.
When ordering equipment for a patient's home, it's really important to consider the type of home setup that they have and the type of bathroom setup that they have. Ideally, you can go to the home and do a home safety assessment, but if the patient refuses or you're unavailable to do a home safety assessment, have them complete the home setup form taking measurements. It's important that you measure the height of the tub if you're going to order a bench like this to make sure that the height of the bench is tall enough to go over the tub. If they have a taller whirlpool type tub or anything like that, this bench won't go over it. Also take a look at this setup here with the toilet. It's a very cramped space. The patient would barely be able to get to the toilet, but if the toilet was over a little closer to the tub or up a little further, they wouldn't be able to get to the toilet with this tub in place. So that would mean they would have to remove the tub every time they take a shower and put it back. So if they're unable to do that, or if their caregiver is elderly and unable to move this, they're probably not going to use it. Also keep in mind, if they have a shower door, they can't use a bench unless they remove the doors and get a curtain instead. So for use of the bench, for a hip patient who's had a total hip arthroplasty, you want to make sure that you order a bench that's back is removable, and you want to remove the back. So when, in this example, we'll say my right hip has been replaced, the patient will walk up to the bench with their walker. In this case, I have a 4-wheeled rolling walker, so I'll make sure to put the brakes on, take my right leg out in front of me and sit down. Okay, so when going to turn, it's important that I keep my hip and my knee in alignment with each other. If I start to turn my knees first without my hips, then my hip is going to be adducted across the midline of my body, and I can't have that. So once I get here, I can bring this left leg up and over. And again, if I just were to bring my right leg up and over without moving my hips first, I would be adducting to do that, and I'm also bending much greater than 90 degrees to do that. So it's important that I first scoot my hips over and get this leg in alignment as far as it will go, and then when I bring the leg up and over, I need to lean back. Like, this is why we have the back removed. When doing this, I don't flex the hip too much, and I scoot my hips over so that I avoid adduction as well. Once in here, I can take my shower. It's important that somebody will be able to help a hip patient to wash and dry their feet and their lower legs, because they won't be able to bend forward like that. They need to stay upright. So once done, it's important that they do dry the bottoms of their feet and their hands very good so that they don't slip on the floor or on the tub or the bench itself. So to come back out, this time I want to make sure I move my leg first and not my hips first. If I were to move my hips first, again, I'm adducted there. So I would move my legs as far as they could go, get my hips over in alignment, and then again lean back, bringing the leg up and over, and then scooting my hips only to midline, and then scooting further, and then getting this leg up and over. And then from there, I can go ahead and stand up once my hands and feet are dry. And that's how to do a tub bench transfer after hip replacement. If your patient doesn't need a tub bench, then you can use a chair. If you're going to order a shower chair for a patient, you want to make sure to have them or yourself measure the width of their tub. Oftentimes these chairs are too wide for a tub. When measuring the tub, if you only measure from the top surfaces, it still may not be good enough because the tubs often bevel as they go down to the bottom, and you want to measure the spot where the legs are going to be. So have the family member, if they're going to do the measuring, make sure to tell them to measure at the bottom, not at the top. You can also recommend a tub mat for the chair so it doesn't scratch the bottom of this tub surface. So in this case, again, I'll have a right hip replacement as an example. When going to get into the tub, what you're going to want to do is have the patient come all the way over as far as they can, put the brakes on their walker if they have them. Now, in order to step my left leg up and over into the tub, I'm going to have to put all my weight on the right side. So that's why you want to have the walker right there for them to do that. They're going to step up and over. And then from here, get over as close as they can. Put their hand on this walker handle and then reach over for the handle on the back surface of the tub. Most showers and tubs will have this handle here. If they didn't, you can order a little horseshoe type of handle that can be clamped on to the tub right here, and they can hold on to that. But again, most of them will have this handle over here. So from here, they're going to scoot as far as they can over to the edge, and then when they go to lift this foot up and over, you just want to watch that they're not bending their hip more than 90 degrees. Most tubs, they should be able to do that, but they might not. In this case, I'm right at 90. So if I was leaning forward at all, I would be bending too much. So it's a better idea to have them instead bend their knee back instead of lifting their hips up forward. So if they can bend their knee back like that and then get their leg in, then they can go ahead and sit down. And again, if they're really tall, this tub bench might not be tall enough. You might have to get a specialty made one that is taller. So they can take their shower, again, dry their hands and feet really well. To go get out, they can stand back up. And then when stepping out, again, same idea. Don't let them bend their hip too much. Once they're out here, shift and come on back out, and they're done.
It is also important to remember that some home adaptive equipment is not covered by insurance plans. Make sure to ask the patient if they'd be willing to pay for it. If they are not willing to pay, then assess to see if there is a second best option for the safest route without the equipment. Make sure to always document what your recommendations are and that the patient declined the equipment. You can also ask them to check with local churches to see if they have any items to donate. If the wheelchair is low and causes the patient's hip to be flexed greater than 90 degrees, then when they sit in it, you will need to put a thick cushion or pillow in it. However, make sure if you do this to place a piece of Dyson between the chair and pillow or cushion to prevent slipping. Always have an elevating leg rest on the involved side. Total knee arthroplasties. According to the American Physical Therapy Association, approximately 180,000 total knee replacements are performed in the U.S. every year. About 90% of those arthroplasties will last 10 years, and 80% will last up to 20 years, depending on activity and use. The types of procedures for total knee arthroplasty are a total knee arthroplasty, which is replacement of the articular surfaces of the femoral condyles, tibial plateau, and patella. The anterior cruciate ligament is excised, but the posterior cruciate ligament may be saved. In a unicompartmental knee arthroplasty, only the medial or lateral tibiofemoral compartment of the knee are replaced. Just like with the hip arthroplasty, knee arthroplasties can be cemented, in which a bone cement or polymethyl methacrylate is used to fix the prosthesis in place in the joint. In this case, they will be weight-bearing as tolerated usually, or an ingrowth or cementless joint arthroplasty in which no cement is used. In this case, they will be partial or toe-touch weight-bearing. Primary joint arthroplasties are a patient's first replacement surgery, and a revision is any succeeding or second surgery, and is usually performed for an unstable, loose, or painful joint, or an infected joint. Evaluation. Therapy evaluation for a total knee arthroplasty should include a review of the surgical report, assessing the incision, knee passive and active range of motion, total lower extremity strength, VMO strength, patellar tracking, edema, functional assessment, a gait assessment for PT, ADL assessment for OT, and pain. Standard knee prostheses allow for 0 to 120 degrees of range of motion after surgery. However, there are some newer advanced prostheses that will allow for up to 130 degrees. They include the LPS, Sigma, CR150, or Scorpio Energy. So if the surgical report states that any of these types of prostheses were used, then range of motion can be allowed to go up to 130 degrees after surgery. If not, range of motion should be stopped at 120 degrees. Recommended outcome measures for PT are the 6-minute walk test, the timed up and go, the dynamic gait index, the Berg balance scale, the lower extremity functional scale, the WOMAC, or the Knee Society scale. Recommended outcome measures for OT, the Barthel Index 100 item, the routine task inventory, and the physical self-maintenance scale. Again, these tests are all located in the functional assessment tools folder in every department. Lower extremity posture should be assessed. Men tend to have a tibial varus posture, which causes medial wear on the prosthesis, and women tend to have a tibial valgus posture due to the increased Q angle from having wider hips, which causes lateral wear on the prosthesis. If there is a malalignment, ask the patient if it was this way before surgery. If it wasn't, then you cannot correct it. You cannot fix a malalignment that occurred during surgery. Post-surgical complications include infection, wound dehiscence or rupture or splitting open of the incision, deep vein thrombosis or pulmonary embolism, effusion, pain, arthropfibrosis, or heterotopic ossification. Warning signs of a possible infection: increased redness, tenderness, or swelling of the knee wound, drainage from the wound, chills or shaking, increased pain with both rest and activity, and fever greater than 100 orally. Warning signs of a possible DVT: increased pain in the calf area, tenderness or redness above or below the knee, increased swelling in the calf, ankle, or foot, or warmth at the knee. Warning signs that a DVT has traveled to the lung are sudden increased shortness of breath, sudden onset of chest pain, and localized chest pain with coughing. Clinical observation of signs and symptoms of a DVT is not reliable. Therefore, it is recommended that testing or a Doppler is done at any suggestion of a DVT. Bear in mind that the prevalence of a DVT after total knee arthroplasty is 50 to 84% in patients who do not receive prophylaxis and 22 to 57% in patients who do. Some physicians use CPM machines and some do not. The research on CPMs is controversial, and when they were originally developed, they were meant to be used 20 hours per day, and when used that way, they showed good outcomes. However, now that mobility is emphasized early on in treatment, they are not used nearly that much, and the outcomes are less favorable. Current research shows that if the CPM is not used for at least 10 hours per day and for 30 days, then the gains will not be worth the cost. An LRU pillow is a wedge that is used in supine to elevate the leg comfortably. It has been shown to be more effective in gaining range of motion than a CPM machine, and it is much lighter and less cumbersome to use. This is what an LRU pillow looks like. The recommended protocol for the LRU pillow is that it should be used 4 hours per shift. You can add ice to increase the effectiveness as well. The patient needs to stay in bed in supine, and the pillow can go home with the patient. The pillow has been shown to significantly reduce edema, which in turn improves quadriceps and VMO function. It is better to limit time up in a chair with the lower extremity elevated and opt for this position instead.
when you have edema at the knee, you want to make sure to determine first if the swelling is on both sides or one. You may not be able to know that, but usually the patient can tell you if their knees are both swollen. If it's a total knee replacement, obviously it's going to be unilateral, but oftentimes with congestive heart failure or other edema problems, it might be bilateral. So if you have bilateral edema and you take measurements, you don't have a normal to compare to, but it's still a good idea to take measurements on both sides so that you can compare eval versus progress reports and discharge to see that you've had a decrease in your edema. You'll have to use your judgment when making a goal for that edema to reduce your measurements by, you can ask the patient about how swollen are you. I think, a half a centimeter to start with. If they get down half a centimeter, then you can always increase that goal. But it's difficult when you don't know what their normal measurements are. If it's unilateral edema, it's easy because you have their opposite side to compare to. Now, when you make your goal, it's a good idea to make your goal for the swollen leg to then be equal to the non-affected leg. But there is always a certain amount of error with your measurements, so it's a good idea to maybe make your goal to be within half a centimeter of the opposite leg throughout your measurements. That gives you a little bit of leeway for that error. So most of your sources will tell you when measuring at the knee to use the landmark of the medial joint line as your starting point. I have found that's easy to palpate in some people, but in people who have a lot of edema or maybe who are a little bit obese and have a lot of adipose tissue, the medial joint line can be very difficult to palpate. So I tend to use the superior patellar border instead. This is always easy to palpate. You just go right to the top of the patella and put your finger along that ridge and make a little mark. Okay. From there, that's your starting point. You're going to want to measure. Again, centimeters is always best with measuring edema. You want to take from that mark 5 centimeters up and 10 centimeters up and make a mark. And then from that line, you'd want to go 5 and 10 centimeters down towards the ankle and make marks. So those are your landmarks that you're going to use to measure circumference. So you want to get the tape around the knee, making sure that it doesn't twist, starting at that superior patellar border and measure the circumference and mark it down. Then you're going to slide up to that 5 centimeters higher, make a mark, and then 10 centimeters higher and make a mark. And then you're going to go down to 5 centimeters below and 10 centimeters below. Obviously, you're going to want to do this on a day that a patient is wearing either loose pants that can be pulled all the way up or shorts. And then you can compare that to the other side. What you generally will see after a knee replacement or a knee injury, you're going to have the measurements at the joint area, like at the superior patellar border, maybe 5 and 10 centimeters up, are going to be larger on the affected side versus the opposite side because you have that swelling in the joint. Generally, you will see the measurements 10 centimeters up and down smaller on the affected side than the opposite side because the swelling generally is around the knee, and once you get up there, there's less swelling, but you also have muscular atrophy, which occurs pretty quickly after a surgery. So your calf muscles and your quadriceps atrophy, making these measurements smaller than the opposite side. So your goals is always to be within about 5.5 centimeters of the opposite side, meaning you're going to reduce the measurements at the joint, getting rid of that swelling using effleurage and ice, and you're going to increase the measurements at the muscular areas by strengthening.
An extensor lag or quadriceps lag occurs when the quadriceps group is unable to contract during terminal knee extension. Edema at the knee can cause this inability, as well as the general trauma following joint replacement surgery. A good way to measure extensor lag is with the patient in supine or long sitting and placing a rolled towel under the Achilles area and allowing the knee to go into passive extension. Measure the knee range of motion in this position. Then ask them to perform a straight leg raise while trying to maintain knee extension and ankle dorsiflexion. Take another measurement with the leg in the air. Subtract the initial measurement from the second measurement, and this gives you the active extensor lag. Example, if a patient's knee extension is -10 degrees with the heel resting on the towel, and when asked to raise the leg, the extension is -25 degrees, then the extensor lag is 15 degrees.
After knee replacement, oftentimes you will see an extensor lag with straight leg raising. It's important that we work on this in a way that you can objectively measure this is through extensor lag measurements. So first, to show what it is, normally when a resident has full extension, they can perform a straight leg raise with their toes in neutral or their foot in neutral and keep that full extension as they lift their leg. So with an extensor lag, they may or may not have full extension to start with, but as they lift their leg into a straight leg raise, their knee bends and they're unable to keep it straight in that terminal knee extension. So the way to measure this is to have them with a small towel roll or some sort of wedge under their ankle so that you're promoting full knee extension. So from there, you're going to take a measurement of what their knee extension is. It may be that they don't have full extension because they just had a knee replacement. Maybe they have some swelling. So you take their measurement there, and then you have them do the straight leg raise. And once it's in the air, you want to have them keep their foot dorsiflexed or in neutral. Measure it again and subtract the first measurement from the second measurement for their extensor lag. So let's say, in this case, that as I measured her down here, she was at -10 or 10 degrees from full extension, 10 degrees flexed. So as she lifted up, I would measure her again. Maybe now she's at -25 from full extension. So in this case, she has an extensor lag of 15 degrees because she's 15 degrees more flexed in her straight leg raise than she was down here in a relaxed position. So that's a good thing that you can make as a goal for your therapy, is to be able to do not just straight leg raises, but straight leg raises without an extensor lag or with less of an extensor lag. So that's a good thing to measure.
PT treatments for total knee arthroplasties should be BID. They should focus on pain reduction and edema control, range of motion, patellar mobilization, thorax, with focus on straight leg raise without an extensor lag, and motor control or retraining of the VMO, functional mobility, bed mobility and transfers, balance, gait and stair climbing at the level that is needed for a safe return home while maintaining the weight-bearing status, car transfers, and scar tissue mobilization. Typically, patients will experience a significant amount of pain after total knee arthroplasty. Pain modalities can and should be used to help reduce the pain and help them to tolerate therapy better. Electrical stimulation can be done using interferential for pain or NMES for assisting with quadriceps strengthening and motor control. Diathermy and ultrasound should not be used directly over metal or over sites where methyl methacrylate is present. In other words, they cannot be done over a cemented arthroplasty. That's why it's important to look at the surgical report when you take the history. Cryotherapy is important. The ice needs to be placed not just in the front, but over the front and back surrounding the knee to help reduce edema. Edema control is very important after total knee arthroplasty. It has been shown that 10 cc's of edema on the knee shuts down the VMO muscle. If this is chronic and continuous, the VMO will atrophy, causing poor patellar tracking. Effleurage can be done using your thumb and index finger, making the shape of an L, and pumping the fluid distal proximal. Avoid downward, lateral, or circular motions. Active, passive, and active-assisted range of motion should be performed daily with each total knee arthroplasty patient. Avoid placing too much overpressure with flexion, passive range of motion, as this causes blanching of the incision, which chokes off the blood flow and decreases healing. This is why it is bad to have a hold time in full flexion with a CPM machine, or to allow prolonged dangling on the edge of the bed when the incision has not healed completely. Emphasis should always be placed on extension, as extension is more important for a normal gait pattern than full flexion is. Do not allow the patient to continuously flex their knee in bed. Instruct them not to put the knees of the bed up. A pillow should be placed under the distal half of the gastrocnemius to facilitate extension. However, patients often tend to move the pillow up below the knee when it becomes uncomfortable, so you may want to put the pillow under the sheet so they can't do that. The patella can become stiff and tight easily after surgery due to less mobility and to edema. This can cause pain and range of motion limitations. Patellar mobilizations should be done in all directions: inferior, superior, medial, and lateral. If there is less mobility in one direction, then more mobs should be done in that direction.
After knee replacement, because the knee is not moving as much, it's very easy for adhesions to occur on the underside of the patella, causing it to not move very well. When that happens, if it gets stuck, it will affect flexion, because as you flex, your patella needs to roll up and down as you flex and extend the knee. So we want to make sure to prevent those adhesions by doing patellar mobilizations. So the way you do that is you find the patella and then just gently move it back and forth, just like this. For this to happen, the patient needs to be very relaxed in the quadriceps area. So teach them to relax and have them just move side to side. Oftentimes, you'll feel one side very restricted and the other side not so much. So if you feel that, you want to go back and forth, and say if it's restricted out laterally, after you do 10 back and forth, you want to have them go just laterally, right out in the resistance, and just keep doing that to try to loosen that restriction. From there, you want to do superior and inferior as well. Now, the superior border of the patella is usually easier to palpate than the inferior border. So I get my fingers on there and start pushing down, and then you can kind of feel with your fingers where that inferior border is popping out. And then you can get a hold of it and move it up and down. Again, if you're restricted inferiorly, then you'd want to keep it out of that end range and do some mobs into that restriction to try to loosen it. So up and down, back and forth. You may hear crunching as this happens. That's some arthritis in the underside of the patella. So you want to do about 10 back and forth, 10 up and down, and teach them to do that several times throughout the day. Now, if a patient's going home, which often they are after a knee replacement, you're going to want to teach them to do this to themselves. You can teach their caregiver if they're unable to do that to themselves, but to teach it for themselves, you're going to want to have them sit up into long sitting and teach them to find the borders of their patella. Now, as soon as they start to do this, they're probably not going to have much luck. It's going to be very stiff. That's because of the position that they're in. Their quadriceps tighten up in this position. So you're going to want to first, before they do that, teach them just to relax these muscles. Try to get them real relaxed, and then try again and see if they can get better movement. There you go. And again, teach them if they have restrictions to then stay out in that restricted area and push further. And then you can teach them superior, inferior as well, finding that superior ridge and pushing down, and then going up and down.
The vastus medialis obliquus, or VMO muscle, is important after knee arthroplasty. Post-surgery, it is common to see increased atrophy at this muscle. The origin of the VMO muscle is the distal half of the intertrochanteric line, medial lip of the linea aspera, proximal part of the medial supracondylar line, tendons of the adductor longus and adductor magnus, and medial intermuscular septum. The VMO has a common insertion with all four quadriceps muscles at the proximal border of the patella and through the patellar ligament to the tuberosity of the tibia. However, the fibers run in a medial lateral direction, leading to the theory that the muscle pulls the patella medially. A weak or atrophied VMO muscle has been associated with poor patellar tracking in the past. However, literature is not consistent with demonstrating whether or not absent or delayed VMO contractions actually cause abnormal patellar tracking or patellar tilt. It has been common practice in therapy to strengthen the VMO muscle to improve patellar tracking. However, some studies are showing that it is impossible to isolate the VMO muscle. However, most patients who undergo knee surgery have had long-term knee pain and likely have lost the motor program for VMO activation at the correct time. One study did show that a delay of as little as 5 milliseconds of the VMO muscle relative to the vastus lateralis can increase the compressive forces on the lateral patellofemoral joint. However, it did not show that the delay caused abnormal patellar tracking. Still, training the quadriceps as a whole has been shown to improve VMO to vastus lateralis timing. Common VMO strengthening and motor control techniques. Biofeedback can be used on the VMO, decreased edema, NMES if they have edema to bypass the reflex inhibition of the VMO that is caused by the edema, straight leg raising with the hips in 30 degrees of external rotation, squats on a ball between the knees, although this should not be done unless the ball is big enough to avoid adduction and internal rotation of the hip joint. In spite of current research on the VMO, patellar tracking should be assessed after surgery, as a weak or delayed VMO contraction is only one of the possible causes of abnormal tracking. Poor patellar tracking occurs when the patella shifts out of place as the knee flexes and extends. In most cases, it shifts too far laterally, although in a few people it shifts medially. Things that can cause poor patellar tracking: a weak VMO, in theory, weak adductor longus, increased Q angle, which is usually larger in women than men, increased valgus deformity, edema, and the incision itself from total knee arthroplasty. The incision for a total knee arthroplasty is typically on the medial side, and the patella is dislocated laterally for the surgery. This adds to poor medial tracking post-op. Edema control can help to reduce the reflex inhibition to the quadriceps muscles. Using NMES on the VMO during quad strengthening and/or biofeedback can also be helpful. Lateral stretching. Typically, there will be tightness in the tensor fascia lata and IT band, leading to lateral retinaculum tightness and increased lateral pull on the patella. Some things that can be done to avoid this are the modified Ober's stretch for the tensor fascia lata, which is a side-lying IT band and hip abductor stretch, or deep friction massage along the IT band and distal aspect where it feeds into the lateral retinaculum, which breaks down adhesions in the IT band, which improves lateral tracking.
To assess lateral tracking, you want to take a look at a patient while their knee is over the edge of the mat and look at their patella, maybe even keep your fingers on their patella, and then palpate their tibial tuberosity. Keep a finger there. Now I'm going to watch as she does a long arc quad exercise and kicks her leg up, and you can see that patella move laterally and then comes back medially as she brings it down. So go ahead and do that again. And it's moving right out laterally and back in. This is very common, especially after knee replacement. Generally, the patient probably had this issue even before their knee replacement, and it may be part of what led to the arthritis and the knee replacement. So one of the most common causes of this is weakness of the medial, or vastus medialis muscle compared to the vastus lateralis. So it can be that this muscle is weaker, or it could be that it's actually a little bit slower to contract than the lateral side is. So we can work on strengthening the muscle itself, but you can also just do general quad sets to promote better timing. Studies have found that just doing a quad set without any focus on the VMO, just doing a quad set will actually improve timing. So straight quad sets, and then you can do your other exercises with a focus on that VMO by just altering your position of the exercise a little bit. Another reason what this can happen is tightness on the lateral side, pulling that patella out. You can have lateral retinaculum tightness or IT band tightness. So we'll show a technique that you can do for some cross friction massage there, and also the Ober's stretch. So let's start with that. So for the go ahead and lie down. For the tightness on the lateral side, have the patient lay on their side with this knee facing up. And go ahead and bend that knee. You can support them with a pillow if needed. What you want to do is just find that IT band right there and just do some cross friction massage on it. This is generally not very pleasant. It's a painful area for most people, and especially if they have tightness there. And just rubbing back and forth like that. You can do some myofascial release as well, just generally a little bit less painful. And just some general trying to get that whole lateral side of the knee with some cross friction and just general mobilization. And you can palpate tightness in tight areas and trying to focus on them. And hope that your patient doesn't cry too much. Okay, you can also do what's called an Ober stretch. Okay, so to stretch this IT band out, it's a very small or tight muscle. It's mostly fascia versus regular muscular tissue, so it's harder to stretch, but you can stretch. I'm going to have the patient go ahead and sit up, and I'm going to have you lie down on your side with your head at this end this time. We'll give her a pillow. So we're going to stretch this left IT band with the Ober stretch. I'm going to have you come all the way back to the back of the table, and you can do this on the edge of a bed or a low mat as well. You're going to bring this right back here, and the Ober's test itself is if I just let this leg go, this is a positive Ober right here because her leg is not dropping down to the table. It's staying up. That's a tight IT band. So what you should see is that dropping down like this, and you can stretch it just like this. Again, you want to make sure she's not rolling back, so you're going to stabilize her hip here and just pull down until the patient tells you they feel a stretch. You feeling that? I'm feeling the stretch. Okay. Now you can kind of alter a little bit more extension or less extension and get various positions, maybe even a little bit of external rotation, and just alter the position to get that IT band all the way through. And that's how you do an Ober stretch. Okay. Now to strengthen the medial side, you want to do the general exercises that we typically do, so go ahead onto your back. Again, just doing a straight quad set has been shown to improve the timing of the VMO versus the vastus lateralis. So I put my hand under their knee, say just press down into my hand. You can see the quadriceps contracting. You want to have her pull her toes up towards her as she does it. Hold for a count of 5 and relax. After a knee replacement, this is generally extremely weak and it's very difficult for them to get a quad contraction. So they may need a lot of help and a lot of work with maybe even cueing like this. And if you're going to tap to cue, tap on the medial side. That way you're going to tap that vastus medialis in there, the VMO, to get more contraction there. From there you can do your short arc quads. Now generally, oftentimes in therapy, I'll use this side. For example, we often do a short arc quad, just having them lift up and down like this. What you can do is have them just turn that toe slightly outward like that, and then do the same thing, lifting that foot down and up. By turning slightly outward, you're getting a better line of pull on the vastus medialis versus the vastus lateralis. So it's just making that work a little bit harder. You can do the same thing with a straight leg raise. So I'm going to pull this out from here. I'm going to have you bend this knee up and then do a straight up leg raise like that is what we typically do, but now have them just turn slightly out like that. Just keeps that line of pull towards the medial side a little bit more. And you can also do it with a long arc quad. So another way that you could do that if the patient is unable to tolerate that position is have them put a little ball between their knees as they say they're doing a long arc quad. Put a little ball between their knees and have them squeeze it and hold it tight as they lift up. I'm sorry, just one leg at a time. Just straightening like that, up and down. Now, if she was also squeezing the ball as she did that, that would also work the medial side a little bit more if maybe she doesn't like turning her toe out. Okay? You wouldn't be able to do that technique with the straight leg raise, but you could do it with a long arc quad. So go ahead and sit on the edge of the table with your feet over there. Another way that you can bias the VMO with a long arc quad, generally we just have them do straight kicking up and down. That's going to get all the quadricep muscles, but to bias the VMO, you could either have her turn her toe outward slightly and kick up and down. If that's hard position for the person to tolerate, you could also just put the ball between the knees and have her do the long arc quad while squeezing the ball. That's going to work the VMO a little bit more.
General strengthening should be done to include quadriceps, hamstrings, straight leg raising with focus on eliminating the extensor lag, and heel slides. Mobility training for PT and OT. Patients need to relearn how to transfer sit to stand without leaning forward and relying on a larger hip extensor movement instead of their quadriceps. Around 4 to 6 weeks post-op, when equal weight can be placed on both legs, they need to be taught to rise from the chair without bending forward excessively. Failure to correct this abnormal pattern could result in the development of future knee osteoarthritis on the uninvolved leg and falling forward. Knee blocking. It's good to avoid knee blocking and use a knee immobilizer if needed, but if the knee is very weak and you are worried about it giving way and you choose to block it, make sure to allow some forward movement Normal sit-to-stand requires anterior movement of the tibia, and this should not be completely restricted, or standing will be more difficult and an abnormal pattern will be learned.
If a patient has a very weak quadriceps or a weak leg for some reason, and you feel the need to block their knee as they stand because you're worried about them standing up and their leg giving out, you want to make sure as you block that knee that you're actually allowing some anterior movement as they stand up. Okay? What we tend to sometimes do is block that knee so tight that as they stand up, it actually makes it hard for them to stand up. Natural motion is to move that knee forward as you stand up. We don't want to teach them an abnormal pattern. So block the knee, but give them some leeway to use it as they stand up. When you have a total knee replacement, the quadriceps are often very, very weak after surgery. So what happens is the patients will want to use their hip extensors and back extensors to compensate for that weak quadriceps as they stand up. So as they stand like this, they tend to do this and stand up. They're going to have to do that at first, but after about 4 weeks after surgery, they should have been strengthening that quadricep enough to avoid doing that. We want to teach them as they stand to stay up tall and avoid that pattern. If we don't teach them that and they continue it, it can lead to advanced arthritis on the other leg or even to falling forward.
Stairs should begin with a step 2 pattern, leading with the uninvolved leg when going up and the involved leg when going down. Progress to a step 3 pattern when able. Car transfers. If the car is low, make sure to have the patient step forward with the involved leg prior to sitting to avoid pain when sitting. Sit first, then turn to get the legs into the car. If the patient is still at the facility after the scar has healed and is clean and dry, then scar tissue mobilization should be done to avoid adhesions.
For scar tissue mobilization, you want to do circles not only over the scar, but around the area of the scar too, because the adhesions can not only form on the scar, but on the area around it as well. So you can do circles with a pretty good firm pressure right over the incision and right around it. You can also just do cross friction, rubbing back and forth over the incision, really a good pressure to try to soften that tissue. You can start with the circles for a good 5 minutes or so to soften everything up. I would use a little lotion, then do some rubbing across back and forth, and you can do rolling or pinching the incision and rolling it between your fingers. All of those will help to soften up that scar tissue and avoid adhesions.
Knee flexion contractures may result from edema, tight hamstrings, a tight capsule or joint adhesions, tight hip flexors, tight gastrocnemius, or from allowing the patient to keep the knee in flexion for prolonged periods, such as when sleeping with a pillow under it. Treatment for OT should consist of balance training, transfers, toilet, tub, and shower, hygiene, ADLs and dressing, adaptive equipment if needed, DME needs assessment for the home, and household activities. For balance progression, focus on balance during functional activities and with the upper extremities reaching outside of the base of support. Adaptive equipment such as reachers, sock aids, long-handled sponges, leg lifters, and long-handled cleaning aids should be kept at each facility to have on hand for practice to see if they need them when returning home. According to Dr. Robert Malloy of the Cleveland Clinic, there is no data to suggest that kneeling is detrimental if the patient has good range of motion after surgery. He does recommend good padding and frequent breaks if kneeling. It typically takes 6 months after surgery for knees to be recovered enough for comfortable kneeling. For wheelchairs, always have an elevating leg rest on the side of the involved leg. Future developments include a minimally invasive surgery. There's a 3 to 5 inch incision, and the surgeon works through the fibers of the quadriceps instead of having to go through the tendon itself. The hope is to cause less pain, quicker recovery time, and increased motion due to less scar tissue formation. Total shoulder arthroplasties. Total shoulder arthroplasty. Indications for surgery include osteoarthritis, rheumatoid arthritis, rotator cuff arthropathy, traumatic arthritis, osteonecrosis, four-part humeral fractures, or failed previous surgeries. Evaluation should include a review of the surgical report, a look at the incision, active and passive range of motion within precautions, total upper extremity strengthening within precautions, edema, functional assessment, gait and transfer training without using the upper extremities for PT, and ADLs without using the upper extremity for OT, pain, and precautions. Suggested outcome measures for OT include the simple shoulder score, the DASH, and the Barthel index. Some suggested outcome measures for PT include the Tonetti, the Berg, and the timed up and go. Complications from the surgery include instability or dislocation of the shoulder, a notching scapula, intraoperative fractures, component loosening, axillary nerve injury, deltoid detachment or avulsion fractures or a tendon rupture, hardware failure, and hematoma or DVT. Total shoulder arthroplasty precautions include no upper extremity extension, external rotation, or horizontal abduction. An example of a total shoulder arthroplasty therapy protocol by John Gose, PT, includes post-op day 1, education on range of motion precautions, an extremity screen, a neuromuscular screen, myotome screen, and mentation. ADL assist capabilities with the arm at waist height, passive range of motion, and disposition limitations. Post-op day 2, passive range of motion, pendulums, ADL assist, mentation, active range of motion of the distal joints. Weeks 1 through 3 consist of scapular stabilization, passive range of motion in the scaption plane, active assisted range of motion in external rotation, adduction and abduction, flexion and extension in a flexed posture, and serratus work. Also isotonics at the elbow and wrist. Weeks 4 through 6 consist of side-lying flexion and external rotation, prone horizontal abduction to neutral, prone extension to neutral, and endurance, such as a UBE in both directions, standing first, then sitting, aquatics when sutures are healed, and go for minutes, not repetitions or sets. Rotator cuff strengthening, active range of motion in all planes within a comfortable range of motion. Use of anti-gravity for extension and horizontal abduction. Isolation of the rotator cuff with Blackburn or Houston exercises. Manual resistance in sitting and supine. And progression with dumbbells and Theratube. Theratube progression is from bilateral to unilateral, slow to rapid movements, predictable to unpredictable, low force to high force, firm surface to unstable surface, bilateral stance to contralateral unilateral stance, eyes open to eyes closed. Reverse total shoulder arthroplasties. Reverse total shoulder arthroplasties were originally used in Europe in the 1980s and received FDA approval for use in the United States in 2004. After a normal total shoulder arthroplasty, if the rotator cuff is weak, the glenohumeral joint is typically superiorly shifted because the rotator cuff is not able to oppose the superior humeral migration. This results in migration of the humeral head superiorly during shoulder elevation with excessive shearing forces with the resultant glenoid component loosening. In the past, shoulder hemiarthroplasties, in which the humeral head only was replaced, were done if there was severe rotator cuff pathology or irreparable damage to the cuff. However, outcomes were limited and overhead motion was unlikely to be achieved. Reverse total shoulder arthroplasties have been shown to have better outcomes than hemiarthroplasties when the rotator cuff is severely weak or absent. Due to the weak or absent rotator cuff, the rehab following a reverse total shoulder arthroplasty is different than the rehab following a traditional arthroplasty. The precautions for reverse arthroplasties are also very different than those for traditional shoulder arthroplasties. The reverse procedure replaces the glenoid fossa with a glenoid base plate and glenosphere, and the humeral head with a shaft and a concave cup. This design alters the center of rotation of the shoulder joint by moving it medially and inferiorly, which allows the deltoid to compensate for the weak rotator cuff muscle. The deltoid then becomes the primary elevator of the shoulder and enables better overhead upper extremity activity. For a review of rotator cuff anatomy, the four muscles of the rotator cuff are the supraspinatus, which lies right above the spine of the scapula, and its main purpose is to assist the deltoid muscle with abduction of the shoulder. It also helps a little bit in external rotation. Below that, below the spine of the scapula, is the infraspinatus muscle, and just below that is the teres minor. These two muscles assist with stabilization of the shoulder and external rotation. And on the underside of the scapula is the big subscapularis muscle, and this muscle is a shoulder internal rotator. When the muscles of the rotator cuff become weak and deficient, particularly the supraspinatus muscle, which tends to get pinched, if they are so weak that they are no longer effective, a reverse total shoulder arthroplasty may be done. With the reverse total shoulder arthroplasty, the ball and socket joint of the shoulder is reversed. There is a ball or a glenosphere that is placed on the scapula and a humeral cup on the head of the humerus, which reverses the ball and socket alignment at the shoulder joint. In this case, this is done because the rotator cuff muscles are deficient and not working, so you will need to instruct the patient to use the larger deltoid muscle to assist in shoulder abduction instead of using the supraspinatus and deltoid together. Average shoulder elevation post-reverse surgery is 105 degrees or more. However, shoulder rotation has not been reported to improve following a reverse operation, and particularly with a weak teres minor, patients tend to have a limited external rotation after the reverse shoulder arthroplasty. Common complications after reverse total shoulder arthroplasty include component instability or dislocation, nerve damage, intraoperative fractures, infection, hematoma, and hardware failure. Key components of rehab after the reverse are joint protection, deltoid function, and establishing appropriate functional and range of motion expectations. Joint protection. There is a higher risk of dislocation after a reverse procedure than with traditional shoulder arthroplasty. Shoulder dislocation in traditional shoulder arthroplasties or hemiarthroplasties or normal shoulders tends to happen in abduction and external rotation. However, after the reverse procedure, dislocations typically occur in internal rotation and adduction in conjunction with extension. The prosthesis slips anteriorly and inferiorly. Functional positions of higher risk for dislocation post-reverse are tucking in a shirt and reaching behind one's hip and low back as if putting a wallet in or out of the pocket. Patients should avoid these activities for no less than 12 weeks following surgery. Deltoid strengthening. Since the rotator cuff is no longer functional, the stability and mobility of the shoulder are now largely dependent upon the deltoid muscle. Biofeedback, which can consist of verbal and tactile cues from the therapist, is useful to assist with learning new recruitment strategies to move the shoulder. Establishing range of motion expectations. Full range of motion should not be anticipated post-reverse surgery. Flexion to 105 degrees is typical. Rotation after surgery varies greatly depending on the strength of the teres minor and the preoperative external rotation abilities. Always use any protocol provided by the surgeon when rehabilitating a postoperative patient. However, if no protocol is provided, you can refer to the Brigham and Women's Hospital protocol on the shared drive.
So when sleeping after a shoulder arthroplasty, it's important that the patient doesn't allow their shoulder to extend, especially because remember, extension is a precaution with both total arthroplasty and reverse arthroplasty. So if you have them lying on their back, they can put a pillow under their hand and wherever it's comfortable for them. And you want to tell the patient, and as long as they can kind of see their elbow as they're lying there, if their elbow's back in a position where if they're looking straight ahead, it's not in their field of vision at all, then it's probably back too far. They want to be able to have a little bit of a view of that elbow. If they do, most likely they'll sleep like this. They're probably not going to want to sleep on their shoulder. That would hurt them. But if they did want to, if they're a side sleeper and they wanted to sleep on the opposite side, you have to be careful. Let me have you roll this way. If she had a right reverse arthroplasty, she's not allowed to internally rotate or adduct. So most likely it's going to fall into that position as she sleeps. So it's important if she has to sleep on her side that she keeps a pillow and keeps it up like this. It gets very difficult though because people tend to roll and toss and turn, and if they do this then it could adduct. But if they keep that pillow there, even if she rolls a little bit, it's really not too bad. So you want to always make sure that they have a pillow under there. If they're a really restless sleeper, they may want to consider some sort of abduction airplane splinting pillow if the doctor orders that, or even a sling, although the sling is going to pull them more into internal rotation. So that would be more if they were a total shoulder arthroplasty and didn't want to externally rotate. To assess for scapulohumeral rhythm, it's ideal to have the patient in a gown or in a situation where you can see their scapula. When you do that, you want to have them elevate their arm in the scapular plane. So you don't want pure abduction or flexion. You want them about 30 degrees forward from pure abduction and elevating in a scapular plane from there. So for normal scapular humeral rhythm, for the first about 30 degrees, it should be pure humeral motion there. The scapula shouldn't move at all. After about 30 degrees, as she elevates it up, you'll see the scapula start to move up, and it superiorly rotates. Now, when she's at pure full abduction, I'm going to palpate here and get the inferior angle of the scapula, about right there, right there. And if you look, it's pretty much right under the armpit there, and as she goes, go ahead and bring your arm down. If I keep my finger there, her scapula is going to move back, but I'm keeping my finger right where it was, and you can see it's pretty much in line with the crease of the armpit or with the armpit. Now, if it was back here when I stopped it, that would show me that her scapula was not moving enough. And so in that case, we would want to work on mobilizing the scapula, stretching it and strengthening it, because you need the muscles to be stronger. What happens is they tend to get stiff, and they get weak and stiff both. So we need to work on both mobilization and stabilization or strengthening of the scapular muscles, the lower trapezius, the rhomboids, latissimus. All those muscles need to be stretched and strengthened. So in this case, again, I'm going to do the scapulohumeral rhythm assessment again. So I'm going to have him elevate his arm in the scapular plane all the way up. Good. And now I'm going to find the inferior angle of the scapula. And it's about right here. Okay, go ahead and let it down. So as he brings it down, you can see my finger's a little bit more posterior than it was before, and that shows that his scapula is not moving quite as much as the previous one. It's important to understand the precautions that go along with shoulder surgeries. and especially the difference between a total shoulder arthroplasty and a reverse shoulder arthroplasty. So for your total shoulder arthroplasty, the precautions are no horizontal abduction, no external rotation, and no extension. So generally, patients tend to dislocate when they abduct and externally rotate. Fortunately, this is not a position we go into often unless you're a pitcher or something like that, which somebody with a shoulder arthroplasty would probably not be able to do anymore. For the reverse arthroplasty, the precautions, again, are no extension. So extension is a precaution for both procedures. But for the reverse, you also are not allowed to internally rotate or adduct. And especially internal rotation and adduction with extension is the position that patients tend to dislocate in. Unfortunately, this is something that we do functionally, such as tucking in the shirt behind you or reaching for your wallet, or especially when with toilet hygiene. So it's important, especially if somebody is a right-handed person and they have a right arthroplasty or left, that they learn to use their non-dominant hand for all of those activities. If they've had a reverse shoulder arthroplasty, the reason they do this procedure is because the rotator cuff muscles are deficient and no longer working. So they may have, over time, by the time they get to the point of needing the surgery, they may have already stopped using this arm for those things. But we do need to let them know for at least 12 weeks post-op, they need to use their other arm for any of those activities that involve this type of motion especially, or any internal rotation. When working on regaining shoulder elevation range of motion after arthroplasty, a good place to start after passive range of motion is with isometric exercises before going into isotonic or isokinetic. So for the total shoulder arthroplasty, we want to really focus on using the rotator cuff muscles and using your scapular stabilizers. So a good way to do that, to make her focus on, instead of just raising her arm up, is to have her use her scapular stabilizers by cueing her. And this is a good way you can do that is, I'm going to tell her to pretend as though she has a band around her wrist and it's tied to her hips and she's unable to lift her arm up. But I'm going to have her try to lift it anyway. So if she does that, go ahead and try to lift, and I'll resist her a little bit, try. And I can feel her scapular stabilizers really working as she does that. Now I'm going to tell her to pretend like there's some glue holding her there. And if she tries really, really hard, she can just barely pull her arm away and lift it up. So if she does that, go ahead and pretend like that's happening and lift. I'm giving her some resistance. And as she does that, just that in your mind of pretending that you're really having to hold it causes her to use those scapular stabilizing muscles a little bit more, as opposed to just lifting and using pure glenohumeral motion. Now remember, after a reverse shoulder arthroplasty, the rotator cuff muscles are deficient and they no longer are able to really assist the scapular humeral motion. Now keep in mind, the ball and socket joint of the shoulder, the purpose of the rotator cuff muscles as she elevates her arm are to allow the humerus to roll and glide within the glenoid fossa. So without those muscles, as she lifts her arm, the humerus could slide up and out. So that's the reason they did the reverse arthroplasty. So now the glenoid fossa actually has the ball and the humerus actually has the socket. So what we want to do, because those rotator cuff muscles are deficient, is teach her to use her deltoid muscle in abduction or elevation purely. And so the way that we can do that is have her do the same isometric, but this time kind of give a little tap on the deltoid and really tell her to use this muscle right here, focus here, and lift, lift, lift. Now we still would want her to use her scapular stabilizing muscles because she should still have rhomboids, lower trap, all of those muscles. She just doesn't have the rotator cuff muscles. So she could still do the same technique of pretending like it's stuck to her hip with glue, but I'm also going to just tap here to really kind of cue her to use this muscle more. So when having her elevate, go ahead and push up. I'm going to tap on this deltoid right here and try to make it work. I'm also going to watch that she's not internally rotating. I want to make sure she stays out in a little bit of an external rotation position. A good way that you can help with that is to actually put a little towel under here, just like that, and then have her go ahead and lift up, and I'm tapping here to cue her to use that deltoid muscle. Before doing the Houston exercises or any kind of elevation type of exercises, oftentimes you'll find that the patient's scapula or scapular area is very stiff. So when they go to move, they tend to either move all scapula or no scapula at all. So if it's very stiff, they might not move their scapula at all. If it's very weak, they might, if their glenohumeral joint itself is very painful, they may want to just move the scapula. So it's important to both mobilize and stabilize the scapula. So if you go to do scapular exercises and they are very stiff, you can loosen a little bit beforehand. First, you can go in and just do some soft tissue mobilization. Generally, you're going to find all kinds of trigger points in the interscapular muscles here, upper traps, and all around the scapula you'll find trigger points. You can do some soft tissue mobilization all over there to loosen it up. And then you can do scapular mobilizations. Now to do that, I'm going to take her arm here. And again, after surgery, she may not be able to come out like this. And you may be down here more, but just kind of hold her in a good position. Generally, the more contact that you have with this arm, the more stable it's going to feel to her. So if I'm holding her like this, she's having to do a lot to hold that up herself, and it doesn't feel as secure. Whereas if I actually put it against my body, get a lot of contact with my arm, then it feels more secure to the patient. They're going to feel a little bit better. So you want them to first just relax. You could even start with some distraction of the shoulder, just pulling out, just to get them to help to relax a little bit. Okay, and then to mobilize the scapula, if I start here and she's real stiff, what's going to happen? Her body's going to kind of roll with it. So you can have her bring this knee up like this. That's going to help stop that a little bit. And then I'm going to get my hand right on the shoulder blade here and just kind of do some rolling, both directions. I find if you kind of do 10 this way and then 10 the other way, the patient gets used to what you're doing and they tend to move with you, and they're not relaxing when they're moving with you. You want them to relax. So I mix it up a little bit. I change directions so that they don't know what to predict. So that way they have no choice but to relax into it and let me move them. So if you're doing this and they're just really stiff and you just can't get anywhere with it, one thing I have found to be very useful is to actually do some mobilizations with and without resistance. And so I'm going to start just with retraction and protraction. So we're going to move, just relax. And this time I'm going to have them start with them just relaxing and I'm just doing the motion so they can get the feel for it. We're going to retract and protract. Okay, as they get the feel for that motion, then I'm going to ask her to start moving with me. So you help me out here, pull back, let it go forward. Okay, and as she gets the feel for that, I'm going to have her do it without me. Okay, so she's doing that on her own. Okay, and now once she gets the feel for that, I'm going to actually resist her. So when she gets all the way protracted out here, I'm going to put my hand here and wait till I say, I'm going to have her pull back and I'm going to give resistance. So pull, 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 pull. There you go, good, good. And I'm just to let her relax and protract back and then pull, good, and relax, pull, and I'm resisting her. Now that she's back here, I'm gonna actually resist the protraction. So push, 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 good, and relax, push. Okay, as you do a few more of those and she gets used to it, you can actually go into both. Pull back and I'm resisting, now push. You wanna resist enough to where they feel it, but they still have some motion. If you resist too hard, they won't be able to move it at all. Okay, after doing that, you can do the same thing with elevation and depression. So just relax and let me move it first. Okay, and elevation tends to be very strong and over strengthened because the upper traps are so overused in general. So it's generally not a hard thing. Depression is a little harder, and it's harder for you to resist because that little inferior angle is harder to palpate. So I usually have her, okay, go ahead and you move with me, okay? And then she can get the feel for it. And then I'll start with the elevation because it's easier. It's really easy to resist it. Just pull up, 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 up. I guess I'm giving too much here. Pull up, good, okay? And then let it come down, pull up, good. And then you do that a few times and then you resist the downward. So go ahead and down and relax and down. And take it up. And then same idea, you can go to where you resist both directions. As the therapist, you want to watch and move your body. I'm pivoting on my body as I do this. If I were holding my core real still and doing this, I would be using all arms and it would be very hard on your body. You want to let your body give the resistance and move so that you don't hurt your back or your shoulder. Okay. From there, after you do that a few times, generally I found those muscles get a little bit fatigued, and then I go to do those same mobilizations, and it moves much more freely because they're not as stiff, and they're a little bit fatigued as well. On the SharePoint drive, you will find the Houston exercises. These are good exercises to do as the precautions allow with your shoulder arthroplasties and your total shoulder arthroplasty patients. Generally, these will be later on as they are able to do strengthening exercises. Follow your protocol. Initially, they're only able to do passive range of motion, and then slowly progress to isometrics and eventually to these exercises. But you want to start with the patient in prone. Now, if you have an older patient who cannot get in this position, we're going to show a modification for this. But for a patient who can, you're going to have them, this is the starting position for the first Houston exercise. And what we're going to work here is just overall all of the scapular stabilizers and rotator cuff muscles. So she's going to start here with her thumb pointed towards her head, and she's going to just lift up. It's just a couple inches that she can lift, hold for a count of 2, and then down again. And you can obviously progress to holding weight as she does this. It's a very small motion. Patients will want to tend to get a bigger motion, and then they'll start to externally rotate and get their shoulder up. You want to avoid that. You just want to work those scapular stabilizing muscles. So after a couple sets of those, you can do the same thing, but this time have her bring her hand up a little bit so her thumb is kind of closer to eye level there, and she's more in a little bit of an elevated position, and then have her do the same thing. This one really isolates that supraspinatus muscle. Just like that. Okay, so now we're going to do the next one. Is very, very similar, except we're having her point her thumb up to the ceiling. What she's doing here is causing a little bit of external rotation at the shoulder. So this is going to target your infraspinatus and your teres minor a little bit more. You're still going to get supraspinatus as well. But lift up, hold for 2, and back down. Same. And then again, you can go up to eye level, and same thing here. And you're going to get kind of overall scapular stabilizers here. Good. And then from there, to really just get the external rotators, the infraspinatus and the teres minor, you want to put her in a 90-degree elbow bent position here and have her just lift, externally rotate, straight up, hold for a count of 2, and back down. And then have her do it herself. And again, it's not a big motion here. Okay. And just go as far as they can, again, without really having to pull the body up. So if she can only go up to neutral, that's fine. That's as far as you want her to go. Okay. And then one exercise that really isolates the teres minor is you bring her down into arm extension, have her thumb pointing out away from her, and then lift up, touch my hand, hold for a count of 2, and then back down. Try not to let her abduct as she does that. Keep it right by your body and lift straight up and down. And those are the Houston exercises. Again, you can find the handout for these on the SharePoint drive, and watch your precautions that you're only doing the ones that they're allowed to do at the time of the exercises and depending on their procedure. For your geriatric patients, a modified way that you can do the Houston exercises without having them to go prone is to have them just sit in their wheelchair and have some pillows propped up against a high table. They can either hold their head like this or with their forehead straight down. They may have trouble breathing that way, but they may not have the neck range of motion to do it this way, so use what's best for your patient. Even if they wanted to hold their head up, they could do that as well. They might get tired doing that though. So whatever's comfortable for your patient. From here, you just do the same exact exercises. You have them pointing their thumb up, lifting up. Now again, after arthroplasty, they may be just doing this right here. They may not have very much range of motion or strength. So you just start wherever they're at and try to get those couple of inches, or as high as you can, up to about here. Again, once you get a couple inches past neutral, if they go any further, they're going to start to substitute all the wrong muscles. So start wherever they're at, and then from here, if they did that one, then they would move it up a little bit and do the same thing. Okay, and then they would do the same thing with their arms pointed up. Now this one may not be possible with a geriatric patient if they don't have the external rotation range of motion for that. But again, you go as far as they can. Maybe they get to here, and that's where you start. You do the exercises. And remember that you're doing this after you're stretching them. So hopefully you'll get some external rotation over a few sessions, and they'll be able to turn out a little bit more and do those exercises. The external rotation, just like this, would be the same way. And then the last one for teres minor may be a little bit more difficult, but you have them put their arm down here, thumb out away from them, and lifting straight up. Now the arm of the wheelchair may get in the way. You can remove that if needed, or you can have them just scoot more forward on the chair. or have them sit in a regular chair. When doing shoulder internal rotation and external rotation exercises with a TheraBand, oftentimes therapists will have the patient hold their elbow in tight against their body and do a straight external and internal rotation. Studies have found that with the shoulder straight down like this, the rotator cuff muscles, particularly the supraspinatus, as it goes through the tunnel, can get the blood supply pinched off a little bit or blanched a little bit. So it's actually better to keep the shoulder more in a scapular plane, and you can do that by putting a towel right under the arm like that. And then instead of going straight out into external rotation, you want to keep it in that good scapular plane of motion by going a little up and out. Now in this case we have the TheraBand down a little lower. You could even go a little lower than this. So she's having to pull up and out as she externally rotates, just like that. Good. For internal rotation, you'd have the patient turn around, step out a little bit more, you'll need more resistance here. And this time I'm going to put the TheraBand up higher so that as she rotates, she'll have to go down and in as she rotates. Again, with the towel in place to protect that rotator cuff muscle. The dynamic hug exercise is excellent for scapular stabilization and strengthening. So what you have the patient do is bring their arms out about 60 degrees abduction and about 45-degree bend at the elbow. So just about like that. And then you're going to have her bring her hands forward and cross slightly over each other and then bring them back. Good. You want to make sure the patient doesn't just let their arms fling back, that they're actually using eccentric control to bring them back slowly. And the important thing too is that it's not just arm motion, that she actually gets her scapula involved. So let me have you turn around. She's going to do this again, and you can see as she brings her arms together, her scapulas are protracting, and as she brings them back, they're retracting. That's what you want to have the patient focus on.
In conclusion, it is not enough that a patient can recite their hip precautions. They also need to be able to perform all of their ADLs while maintaining them. After total hip arthroplasty, focus of strengthening should be on hip abductors, and gait should focus on decreasing the Trendelenburg gait pattern and increasing hip extension. After total knee arthroplasty, focus should be in gaining full range of motion 0 to 120 degrees, reducing edema, and VMO strengthening. Always educate caregivers on how to assist the patient. In order to receive your CEU certificate, please complete the post-test and course eval form. If you have any questions regarding the program, please email clinicalservices@blueskytherapy.net.